This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everyone, and thank you for joining us today for our HealthyU webinar on Can You Prevent Colon Cancer? At any time during the presentation, you could enter any questions you have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenters are Dr. Chris Laskaridis and Dr. Ramona Rajapaksa. Dr. Laskaridis is a board-certified gastroenterologist and a founding member of Mather Gastroenterology. He completed his medical degree at NYU School of Medicine and his internship and residency at the prestigious NYU Bellevue Internal Medicine Residency Program. During his time at Stony Brook, he spearheaded expanded access to outpatient gastroenterological care and colorectal cancer screening. As a 9/11 first responder, he has dedicated 2 decades of his career to providing unsurpassed care to Long Island's World Trade Center responders. Dr. Laskaridis specializes in colon cancer screening and is highly skilled in performing endoscopic procedures, including colonoscopy, sigmoidoscopy, upper endoscopy, and small bowel video capsule endoscopy. Dr. Rajapaksa obtained her medical degree from the Royal College of Surgeons in Ireland. She's a fellow of the Royal College of Physicians in England, a fellow of the American College of Gastroenterology in the US. Prior to joining Mather Gastroenterology, she was at Stony Brook University School of Medicine, where she was on the faculty in the Division of Gastroenterology for 20 years. At Stony Brook, she was the director of the Inflammatory Bowel Disease Center. She has partnered with the Crohn's and Colitis Foundation to educate the community and fundraise for research. In addition, she is active in the National Public Policy Council of the American College of Gastroenterology. She's board certified in gastroenterology and has a special interest in inflammatory bowel disease and women's health issues, in addition to general gastroenterology and colon cancer screening. Right now, we are going to turn it over to John. Are you there?
Yes, hello.
Hi.
Hello all, thank you for joining us this afternoon. My name is John Mako. I am the secretary for the Brookhaven branch of the NAACP. And I'm here today with our branch president, Dr. Georgette Greer-Key, and we're excited to be co-sponsoring this event with Mather Hospital. And if you would like to know more about our branch, you can find us on Facebook. Just search for Brookhaven NAACP, or visit our website at brookhavennaacp.org. And we are happy to be doing this and excited to be hearing this presentation from Dr. Laskaridis and Dr. Rajapaksa. And by all means, please take it away.
Dr. Laskaridis?
Okay, so we can go ahead to the next slide. So whenever you talk about trying to do a screening program for any particular disease, if you're going to design that program, you have to have certain criteria involved for it to be worthwhile. So this slide goes over the criteria that you want in order to set up a program. So you need to have a preclinical period that the disease escapes the cure. Treatment must be more effective early on, and the disease needs to be common in the population that you're actually going to be performing screening on. Let's go to the next slide. So this talks about a little bit about lead time bias. And so when you're looking at the particular disease and you're going to do a screening test, you want to make sure that you don't just detect the disease earlier, but you have the same outcome at the end. So if you look at the slide, the first line shows the diagnosis of the disease in a given individual, with the end game, in this case being death, at a given point. If you have lead time bias, all it means, which is in the second line, is that you detect the disease earlier on, but you make no impact in the actual person's overall health because the end game is at the same exact time. So what we're looking to do in a good screening test is we want to catch things early, and we want to have improved survival, as is shown in the third line on this slide. Next slide. So you want a highly sensitive test where you can detect the ability to detect everybody that has the disease, but you want the test to also be very specific because you don't want to pick up people who don't have the disease. So there should be a high predictive value. The test should be very simple to do. It should have low cost and it should be safe. You don't want to end up creating more harm than is necessary. Next slide. So what can go wrong with screening? You can have uncomfortableness with procedures. You could potentially have radiation effects if it involved an imaging study. False positive tests can cause additional workup that is unnecessary. And then there's always the risk of pseudodisease where you're overdiagnosing things that are clinically not significant or not more curable at an early stage. Next slide. So getting into colon cancer specifically, this is a cancer of the lining of the colon and the rectum. It's also known as the large intestine. The colon cancers are both influenced by genetic and environmental factors. 90% of cases do occur after 50 years old, and the overall 5-year survival is approximately 61%. Next slide. So this is an image of a colon cancer that we typically see during a colonoscopy. The importance of this slide is that most cancers are very asymptomatic in the early stages. There can be some symptoms which can include constipation, weight loss, bleeding, anemia, and abdominal pain, but those usually occur later on. Your doctor may ask you those questions to see if there's any additional therapy or interventions that need to be done, but just because you would answer no to those questions does not mean you should not undergo screening. Next slide. So again, to summarize on, is there a preclinical period present with this? Can it be cured early? Is treatment more effective early on in colon cancer patient? And is colon cancer common in the population? Let's explore this. Next slide. So there are 150,000 cases of colon cancer diagnosed in the United States every year. 9% of all cancer deaths are due to colorectal cancer. The lifetime incidence of colon cancer is about 5% in the US population. And there are about 40 to 50,000 deaths every year from colon cancer. So it is very common in our population. The graph here shows how the rate increases dramatically after approximately 50 years old. Next slide. So is there a preclinical period where you can actually do some good? And the answer is an astounding absolutely. These are pictures of colon polyps that you can see that look like berries coming off of the lining of the colon. These are benign growths that turn into colon cancer. And so if you intervene at this stage and you remove these polyps, you prevent colon cancer from ever happening. Next slide. So these are precancerous growths in the colon. They occur in approximately 25 to 30% of people at age 50, and they go up to approximately 50% in patients that are up to 70 years old. Next slide. 1 to 4% of people 20 to 30 years old have polyps, so it's not really common in young people. The incidence increases with age, and they can develop into cancer in as little as 7 years. 90% of colon cancer deaths are thought to be totally preventable by early detection and removing these polyps. Next slide. So the colon cancer life cycle is shown in this slide. So you go from normal colon lining on the left towards the polyp, which is the precancerous condition in the center slide, and colon cancer, which is shown on the left slide. Next slide. Can colonoscopy prevent cancer? Yes. How do we do that? We remove polyps. The vast majority of polyps are removed during a colonoscopy. They generally are removed either with a biopsy forceps, which is shown on the left picture, or with an endoscopic snare, which looks like a lasso from on the right-hand picture. Next slide. So does polypectomy work? There was a landmark article in 1993 in the New England Journal of Medicine where they actually looked into this to see if removing polyps stopped colon cancer. Next slide. So what this slide shows is that they looked at people who had colonoscopies subsequent to having had polyps removed. And based on the historical data, they expected to have anywhere from 20 to 48 colon cancers detected in this population. And what they did find was only 5 cancers. So the percent reduction of cancers by removing polyps was anywhere from 75 to 90% reduction by removing polyps. This was the landmark study that told us that you need to remove polyps. Next slide. So this is another slide that shows this more graphically. The upper lines, the upper three lines are the amount of cancers that they expected over a 7-year follow-up, and the solid black line at the bottom is what actually took place because polyps were removed. We're going to go to the next slide, and then Dr. Rajapaksa is going to take over.
So, hello and good afternoon. Thank you for that very informative first half of the presentation, Dr. Laskaridis. So he went over sort of colon cancer and the pathophysiology and why we should screen. So I'm going to take you into the logistics. So is early treatment better? Well, survival depends on the stage of the cancer at diagnosis. And staging is usually numbered 1, 2, 3, 4. And each stage is dependent on certain variables. So we use what we call the TNM system, which is based on the extent of tumor, whether there's lymph node involvement, and whether there are metastases. Next slide, please. So this is just a schematic representation of TNM staging. As you can see to your left, stage 0, there's no spread. Stage 1 is just through the inner lining, and you go all the way through to stage 4, where it has spread through the wall into the blood vessels and spread to distal organs. So you really want to try and prevent that. Next slide, please. Now, we know that survival depends on how advanced the cancer is. Survival is best in the early stages and is least when it's already stage 4. So you really want to try and prevent colon cancer. You really don't want to wait until it becomes cancer before you find it. Now, this is data from rectal cancer, and you can see the difference between stage 1 and stage 4. Some of this data that, is different for colon cancer, but it illustrates the point that there's a big difference between finding a cancer at stage 1 and finding one at stage 4. Next slide, please. So what are the screening methods? Well, we have stool tests, which a lot of patients actually ask about. The old one was stool Codswell cult blood. Nowadays, we have the newer stool DNA testing. Barium enema has really sort of fallen out of favor, and we really don't use it for colon cancer screening. There's CT colonography, flexible sigmoidoscopy, which involves just passage of the scope into just the left side of the colon, and colonoscopy, which is highlighted because it is the gold standard and considered the tier 1 test. Next slide, please. So what is a colonoscopy or a colonoscope? It's essentially a flexible tube that has a number of channels. There's a light source in it. There's a suction channel, so we can suck fluids up and we can suck polyps up through it. There are water jets so that we can actually clean the colon and clean the lens. And then there's a channel through which we can pass instruments such as the biopsy forceps that you see to the left, which we would use to pick out any small polyps. Next slide, please. So what are the roadblocks? Well, the roadblocks we face when doing a colonoscopy is colon cleansing. The colon is normally full of stool to different degrees, and we do need to clean it so that we can see. Without a clean colon, we don't get a good imaging study, and we can't really rule out polyps. Patients are often concerned about discomfort during the procedure. Next slide. So let's talk about the preparation. Well, 24 hours prior to the examination, we usually recommend a clear liquid diet, such as water, apple juice, broth, or jello. We say that there shouldn't be any solid food on the day prior to the examination. And then we start with laxatives around 5 o'clock the evening before. And diarrhea begins shortly thereafter and can last up to about 5 hours, but it really varies depending on the individual. Next slide, please. So what are the prep solutions? Well, a long time ago, we were using Go Lightly, which is the gallon of stuff that you see on your lower left-hand corner. Not very popular. It tastes like seawater, and it's quite unpleasant, even with the flavor packets. There was Fleet's phosphor soda, the one in the middle that we used for a while, but fell out of favor again because of electrolyte disturbances. Magnesium citrate is used by some people. Half Lightly is used by others. There are many different preparations out there. Next slide, please. The one that we prefer and the one that I prefer is this one, Miralax, which is essentially PEG. It's essentially the same chemical compound that's in Go Lightly, but it's in powder form, and you can dissolve it in a liquid of your choice, and it's only 64 ounces as opposed to a gallon. The advantage is that it's tasteless, flavorless, odorless, so it doesn't really change the taste of the liquid you dissolve it in. And so some of the examples there are things like iced tea, Gatorade. I recommend something like vitamin water. It goes down nicely. And most people actually find it not so unpleasant. The other important thing about Miralax is that it's kind of like a wash for your colon. So it just goes straight through. It's not absorbed into your blood. So it can be used safely in patients who have, for example, cardiac failure or patients who have kidney problems. It doesn't affect the electrolytes. Next slide, please. Now, the other thing that patients worry about is discomfort. Well, the most discomfort you usually have is really that preparation and running back and forth to the bathroom. But the procedure itself is painless because it's done under sedation. So we have anesthesia. Anesthesia puts in an intravenous into your arm and then gives you propofol. We call it conscious sedation because you're unaware, but on the other hand, you're still doing your own breathing. You're not on a breathing machine or anything like that. And of course, we keep you safe by monitoring your heart rate, blood pressure, oxygen, and so on during the procedure. Next slide, please. So as Dr. Laskaridis mentioned, what are our goals of screening? Is a detectable preclinical period present? Yes. A resounding yes, actually, because colon cancer begins in polyps and therefore can be prevented. Can colon cancer be cured early? Yes, by removing polyps. Is treatment more effective in the early stages? Yes, it doesn't fall under that lead time bias that some cancers have. And it is actually fairly common in the population. I just wanted to, again, highlight, some of the facts about colon cancer. As Dr. Laskaridis mentioned, it accounts for approximately 50,000 deaths, cancer deaths per year in the United States. It's actually only second to lung cancer as a cause of cancer deaths. And the interesting fact is that it's 20% higher in minorities. So there's a disproportionate number of minorities with colon cancer and colon polyps. And in African Americans, they have a 40% higher incidence of colon cancer death compared to the general population. So this is a very important area that needs to be explored. Next slide, please. So according to the guidelines, there are several different guidelines that we use. There are the American Cancer Society, American College of Gastroenterology, American Gastro Association. But essentially, we start screening at age 50. Screening should begin at age 45 in any patient in African Americans, and at age 40 for any patient who has a family history of colon cancer. Of course, if you have other conditions that increase your risk of colon cancer, such as inflammatory bowel disease, or if you have a family history of colon cancer, then your screening would have to start earlier, and it's something you should discuss with your physician. And what are the tests that are available? As we discussed earlier, there's the fecal DNA, the Cologuard, which most of you may have heard of. I think everyone's heard about Cologuard and colonoscopy pretty much. And the important thing to remember is that the Cologuard is a DNA test. It detects cancer. It's very poor at detecting polyps. It's something like a 40% detection rate for large polyps. So if you want to wait until you get cancer, then it's a good test. But if you don't want to get cancer and you want to remove the polyp before it gets cancer, then it's not a good test. It's done every 3 years. Whereas colonoscopy is really about every 10 years if you don't have any other risk factors and there are no polyps found. So it's actually cost effective as well. And the United States Multi-Society Task Force actually recommends colonoscopy as the tier 1 test. Next slide, please. So, and what we found is that less than 60% of patients over the age of 50 have received appropriate screening. And actually, the American Cancer Society and a colorectal cancer screening consortium actually had wanted to have 80% screening by 2018, but unfortunately that really didn't happen, which is one of the reasons why we need to have more discussions like this and lectures like this to educate the public about colon cancer and why it's important to screen. Next slide, please. So colonoscopy should be performed by well-trained gastroenterologists. And as we said, it's the tier 1 test. And the reason it's the tier 1 test is because it prevents colon cancer and not just detects it. And other options should be considered as secondary test if a patient just doesn't want to have a colonoscopy or if it's not feasible for some other reason. Next slide, please. Yeah, I just put in this slide, you know, patients are always asked about cost and cost of colonoscopy. Now, all the private payers pay fully for screening colonoscopies and polypectomies. Medicare, there was a little loophole in Medicare that would prevent some patients from being fully covered if a polyp was found during a colonoscopy. So they would cover the screening colonoscopy, but not the polypectomy. Well, all the different groups, the gastroenterology groups, have been working on this for several years. And as part of the Public Policy Council of the American College, I was very gratified and to be able to meet Rep. Donald Payne, who's the congressman from New Jersey, who actually sponsored this bill, removing barriers to colorectal cancer screening, which was signed into law by President Trump before he ended his term in December 2020. So now there is absolutely no surprise billing for Medicare patients when a polyp is removed during colonoscopy. So it's all covered by insurance. Next slide, please. At Mather Gastroenterology, we have a direct access program for patients who are in good health and who have no medical problems. We want to increase access to colonoscopies and make it easy for our patients so that you don't have to take a day off work to come to the office and then take off work again for the procedure. So all it requires is a phone call to our office. We require a note from your primary care physician, and then our nurses will go through a history with you and determine if you can take advantage of the direct access program or whether you need to come to the office. And of course, if you want to come to the office, we're always happy to see you. Next slide, please. So in conclusion, ultimately, the best screening test is the one that gets performed. So, so whichever one you pick, just be fully informed about the potential advantages and disadvantages of them. Colonoscopy is the gold standard because it prevents and detects colon cancer. So I think I'll end there and we'll take any questions. Thank you.
Thank you, Dr. Lascavidi and Dr. Rajapaksa for your extremely informative presentation. If anyone has any questions, you can enter them now in the Q&A feature on the bottom of your screen. Again, all questions are anonymous to protect your privacy. And I think we have a couple of questions. The first one is, I am a 70-year-old male and never had a colonoscopy. Should I still get one?
Do you want to take that, Chris?
I guess I'll take that. Absolutely. If you're 70 years old and healthy, you should absolutely get one. The guidelines say that between 50 and 75 years old, we should perform routine colon cancer screening. After 75, it becomes a discussion with your doctor based on your health. But at 70 years old, you should definitely be having this discussion to have a colonoscopy.
Okay. Next question. I'm sorry. Next question here is, what do you think about FIT as a screening tool?
So FIT is a stool DNA test, and it's less sensitive than a Cologuard. It detects about 70% of colon cancers as opposed to Cologuard, which is more in the 80 to 90%. Again, it only detects colon cancer. It doesn't detect colon polyps, and it has therefore to be done yearly as a screening tool. And for all those reasons, it's not considered a gold standard. There are also false negatives, false false positives. False negative is the one that you really worry about, because with Cologuard, there's a 10% chance of a false negative, meaning you can have colon cancer and still not detect it with the Cologuard. And with FIT, it's similar.
Our next question is about, are there any foods that you should avoid?
Yeah, assuming that is referring to foods that put you at risk for colon cancer and not with regards to the PrEP. Generally, we believe that high fiber foods tend to be better to promote good colon health, and that when you look at some of the discrepancies between colon cancer rates around the world, it's likely that we don't have enough fiber in our diet in the United States, and that we have too much fat in our diet. So generally, we promote a high fiber, low fat diet, which is good for cardiovascular health as well.
Yeah, I just wanted to add a little bit to that. It's exactly the vegetables, also red meat. There is some data to suggest that eating a lot of red meat might put you at risk. And then there are other things like exercise and just keeping in general good health, is supposed to be good for your colon as well, aside from, for your cardiovascular health.
Okay, another question. Could you please go into more detail about detecting and treating colorectal cancer?
Want to take that one? We detect colon cancers during the colonoscopy. As far as treating them, if the colon cancer is within a polyp that you remove and it's not within the margin of the removal area, then you don't need any further therapy. If it does get into the wall of the colon, then you are looking at surgery to remove the wall and the local lymph nodes for further diagnosis. And then, you get into do you need chemotherapy or radiation? But that's more of a question that a medical oncologist would have to answer with you.
Okay. Is it necessary to have a colonoscopy yearly if a polyp of a certain type was found and removed?
Usually the short answer is no, usually not. However, there are certain types of situations where one may need to have a colonoscopy sooner. So for example, if you remove a polyp that's greater than 2 centimeters and it's removed in a certain way, then the recommendation is that you come back in 6 months to visualize the site and make sure that it hasn't come back. And of course, if you're in a high risk category like inflammatory bowel disease, or you have a family history of colon cancer, there are certain colon cancer, polyposis and things like that. In that case, you may need to have yearly colonoscopies. So there are specific situations when the answer is yes. But in general, for people without risk factors and without any of these strange polyps, no.
How soon before a colonoscopy should a person stop taking blood thinners such as Plavix, Aspirin, or Xarelto?
So this should always be a discussion with either your primary care doctor, gastroenterologist, and sometimes even cardiologist. Aspirin can usually be continued during the procedure, but Plavix is generally 5 days beforehand. Xarelto is usually 48 hours beforehand. But when we start to get into discussions with blood thinners, it needs to be more of a specific discussion between all your providers to make sure that it is actually safe to stop the blood thinners.
Another question. I have had UC for approximately 30 years. How often should I undergo a colonoscopy?
The current recommendation is every 1 to 2 years. That's a simple answer. But obviously that changes a little bit if there were anything found during the colonoscopy. So for example, if dysplasia was found, or there were, anything like that, then you may need to go even more frequently, sometimes every 3 to 6 months. So it really depends on the finding. But in general, after 30 years of ulcerative colitis, the answer is every 1 to 2 years.
Okay. Are there any specific symptoms or signs that should be considered or looked at for colon cancer?
So I did touch on this a little bit before. There can be symptoms with colon cancer. Early on, there are no symptoms. And so a lack of symptoms does not get you, it's not a get out of jail free card to avoid a colonoscopy, because early colon cancers are asymptomatic. But there are things such as bleeding, anemia, abdominal discomfort, straining, constipation, thinning of stools that can be worrisome that you could have a colon cancer. But the point of this is we're trying to catch you before you ever develop the colon cancer. And so we really want to perform colonoscopies on people early before they develop any symptoms.
Okay. Is 10 years for screening the gold standard? I was told by a physician to get screened every 5 years. I'm 70 and had my test 5 years ago.
The current recommendations are that if you don't have a family history and the person performing the colonoscopy was happy with the prep and happy with the examination, then it should be 10 years. However, sometimes that number changes depending on whether there was a history of polyps, whether the examination wasn't as good as one would have hoped for with prep and so on. And of course, if there are polyps, then it's sooner. But yes, 10 years without anything.
Okay. How often should one have a colonoscopy after having a sigmoid resection with stage 3A?
So generally speaking, that's a more difficult question to answer. It depends on whether or not they were able to visualize the entire colon prior to the sigmoid resection. If that was not available, then sometime after the procedure, the resection, you should have a repeat colonoscopy. Generally, people will then do a follow-up, usually within a year. And then depending on how you do, then the interval will slowly increase after that, every 2 years, every 3 years after that. But it's not quite as ingrained as some of the other recommendations. And so it's best to have a discussion with your gastroenterologist.
And a final question here about after having a colonoscopy, is it necessary to have someone to drive me home?
If you have sedation, yes. We use sedation, propofol, and what that does is it sort of impairs your judgment. So you sort of feel perfectly fine and you feel like you can do anything, but it's like drinking alcohol. And so we don't want you to drive or operate heavy machinery or go signing papers that are important for your life or anything like that within 12 hours of the procedure. So yes, you do need a ride if you have sedation. There are occasionally patients who don't want sedation during a colonoscopy, and if you don't have sedation, then you don't need a ride home.
Okay. And we have one more question. Is a stool test enough? I am 77 years old and all my stool tests were okay.
Again, that's a little bit of a loaded question. Routine screening is recommended up until 75 years old. After 75 years old, it depends on your overall health. And so not having those specifics, I can't say whether or not you should, but assuming that you are a healthy person, all the stool test really means is that at that moment, there was no either DNA shed or blood shed to turn your test positive. It does not mean that there is not a polyp in there that could become a polyp, that could become a cancer within the next few years. And so generally speaking, if you're a healthy individual, colonoscopy is the gold standard to make sure that there are no dangerous lesions in the colon.
Okay, and we have another one now. I have had a 10 millimeter and the following year, a 7 millimeter polyp removed. Should it be necessary to have another colonoscopy yearly because of this?
It depends on the pathology and it depends on the practitioner and what they thought of the examination. And if you have a family history, if it was a good examination and it appears that you're making polyps, on a yearly basis, then it would mean that you would need more frequent colonoscopies. But otherwise, you could probably put it off a little longer. It's a discussion that you need to have with your gastroenterologist based on multiple factors.
Okay, why don't we give it another minute to see if there are any more questions? I don't see any now. While we're waiting, just to let everyone know, once you exit the webinar, you will be redirected to complete a brief survey. If you could please complete the survey, your feedback is extremely important to us and helps us plan our future webinars. And if you would like to view other HealthyU webinars we have presented, you can find them at www.matherhospital.org/HealthyU. I see no more questions, so I just want to thank our presenters and thank everyone for participating in the webinar. Thank you and have a good afternoon.
Thank you.